series of understanding and responding to mass incarceration 2021 events. Really glad you're here. My name's Theresa Libby. I'm a faculty member here at Metropolitan State, and my pronouns are she, her. I'm going to turn it over to Dr. Rosh, who's going to do our land and enslavement acknowledgement.
Yeah, thank you. Thank you, Libby, and thank you to the team for helping us with this crazy work of organizing this every year. So we were absent last year. We were frantically figuring out how do we do this in-person conference online. So, but here it is, right? I want to, at this point, just invite you to focus on your breath and come into this space. If you will, just focus on your breath. And if you're okay, close your eyes and breathe. As you breathe in and breathe out, I want to invite you to feel your feet on the ground, right? Feel that feet on the ground as if you have never felt it. Right? Acknowledge the land that we are standing on, right? In the community that we're with. Right? We keep hearing all kinds of news. So as Income Ndofe often says, right, a healer, she say, we have to check on our cognitive wellness and our emotional wellness and our body, right? So as you breathe in and breathe out, I invite you to just scan your body, right? Breathe in, breathe out, check for tensions in your body, stresses in your body. Where are you holding? Right? Some of us hold it in our jaw area, in our neck, in our back, right? In our knees. Wherever you are holding it, just want to gently Oh, I've been on mute. Is that, am I good? Can you hear me? Good. Was practicing my own breathing. So when good morning. I want to appreciate all of those amazing souls and spirits who have been with us forever right now, helping us to put this together. I want to acknowledge all of them because this is a village. It takes a village to do this. I want to invite you at this point, right? Real quickly, let us just focus on our breath and help center us. Right? If you will, find a place to set your gaze, otherwise gently close your eyes and breathe in and breathe out. Breathe in and breathe out. In and out. And as you breathe in, I want to invite you to feel your feet on the ground, right? Let Mother Earth support us. Feel that feet on the ground as if you've never felt that way, right? And gently drop your weight from your head to your neck, to your shoulder, to your back, to your knee, and on to the ground. I want to invite you to breathe in and breathe out and just check your body, do your scanning, right? Income Ndofe, who's a healer, right? Amazing sister, often talks about cognitive wellness, emotional wellness, and then how our body shows up in spaces, right? And want to invite us to check in with our body, right? Tensions, stress points that we are holding, right? Just kind of gently scan your body, right? Your jaw area, your back, right? Sometimes your knees. So if you recognize tensions and stresses, I want to invite you to breathe into those spaces, right? Take a deep breath. Hold that breath and release it. Exhale through your mouth. Take another deep breath. Hold that breath, and exhale through your mouth. Continue breathing. I'm going to do a quick Land and Enslavement poetry by Michelle Armster, right? Great, amazing sister, right? Wrote this poem, A Vision for Justice. Long, long time ago, or was it last year? Or was it yesterday? A seed, yes, a justice tree seed was planted. But how will it grow? How will this justice tree grow when the ground is poisoned with lies and broken treaties? How will it grow when water spills the blood of African and indigenous bodies? How will it grow when the stories of the settlers is the sun that scorches the earth, burns our backs and drinks our tears? And yes, we know that our stories are not the same. And we know, yes, we know that justice has to be a verb. And we know that this work, our work, is all about our babies, taking care of the babies until the 7 generations. The babies we must love in ourselves, in our homes, in our communities, and yes, in our streets. Bearing witness, we have to create a safe, brave space. We learn from the past to see the future. They say Sankofa. As you breathe, we tell our stories, and then, maybe then, this moment, yes, this moment becomes a movement, right? As you breathe in and breathe out, I want to invite you to, right, process those words, the narrative, the imageries, right? And move from your head space to your heart space, right? I want to invite us to be in our heart space and recognize our body. How do you feel? Where are your tensions and your stresses, right? Check in with your body as you come into your heart space, right? We've been in all kinds of tense moments in Minnesota, right? Since last May, we've been hit with dual pandemics. The virus and the virus racism, much, much prevalent, much, much more obvious in our communities, in our streets, right? And in our professional world. So I want to invite us to be present, to listen, to learn, right? So that we can together lead. Right? It is important for us to really recognize our heart space, recognize our body, right? I want to invite us to, right, be a part of a community that does hard work, not hard work. So with that, I want to appreciate and invite Dr. Libby to lead us in a moment of silence, and appreciate all of you. Just continue breathing. Appreciate.
Thank you, Dr. Raj. Thank you for bringing us fully into the room and fully into an acknowledgement of what and what we owe to this land and what we owe to the people who have been slaughtered and enslaved, and whose descendants live with the consequences. I too want to acknowledge the events that have been taking place and are taking place here with the George Floyd trial, the murder of Daunte Wright, and the newly released images of Adam Toledo in Chicago, a 13-year-old Black boy who died with his hands in the air. These murders are part of the same white supremacist system that incarcerates Black Minnesotans at 11 times the rate of white Minnesotans. I would now like to have a moment of silence for Daunte Wright and those like him who have died from state-sponsored violence. Daunte Wright, we speak your name. Someone has pointed out to me that it is the trial of the police officer, not that of George Floyd. He is indeed not on trial. We all know what happened. We've seen it. And forgive me for phrasing that incorrectly. Again, welcome to Understanding and Responding to Mass Incarceration. URMI, it's been an annual event here at Metro State since 2014, and we examine the phenomenon of mass incarceration with a different lens each year. Our 2020 event, which was canceled, our theme was mental illness, public wellness. So we've carried this theme into 2021, and we're offering it as a series. This is the first in 4 that we'll be offering this year. I want to acknowledge the campus offices that are supporting today's event. I want to thank Dean Maya Sullivan for the allocation from the Community Health Collaborative Grant from the Office of the Dean of Students. I want to acknowledge Provost Amy Gort and her office, and President Jenny Arthur and her office. We are ever so grateful for the strong institutional support that this event receives. In a moment, I'll introduce our speaker, Alisa Roth. She'll speak until approximately 9:50, after which we'll have time for Q&A. Dr. Darshini Gunathaleka, faculty here at Metropolitan State, will be selecting questions from the chat and posing them to Ms. Roth. And we are asking that you refrain, and this will show up in the chat from time to time, that you refrain from putting your questions in the chat until about 10 minutes, until about 9:40. We'll then take a break after the Q&A until about 10:25. And following that, Dr. Raj will give us our charge for circle discussions in breakout rooms. And we'll wrap up with a report out that he will facilitate and a closing, finishing at about 11:45. I want to be sure that everyone knows that Ms. Roth's talk is being audio recorded by MPR and video recorded by Metropolitan State. And as always, please, as always in Zoom meetings, be aware of keeping your mic muted. It's now my honor and pleasure to introduce our speaker. Journalist Alisa Roth is the author of Insane, America's Criminal Treatment of Mental Illness, an investigation into the crisis of mental illness in the U.S. criminal justice system. A former staff reporter at Marketplace, Roth's work has also appeared on NPR and in the New York Times and New York Review of Books. As a 2014-2015 Soros Justice Fellow, Alisa spent a year investigating the growing role of jails and prisons as our de facto mental health care system. She has visited the country's 3 largest psychiatric care providers, Rikers Island in New York City, the Cook County Jail in Chicago, and the Los Angeles County Jail in LA. And her research has included dozens of interviews with prisoners and their families, psychiatrists, lawyers, wardens, corrections officers, and others. Ms. Roth, we welcome you and thank you so much for joining us today. Brian or Jody, can you unmute Ms. Roth, please? And I see there's another correction for me in the chat. Adam Toledo was Latino, and I apologize again.
Well, it wouldn't be a Zoom conference if somebody couldn't unmute themselves, right? So thank you, Theresa, for that kind introduction, and thank you to Jody and Brian for the technical help, and Raj for that lovely opening, and Darshini, I'm looking forward to our conversation afterwards. And thank you to the Metropolitan State team for inviting me today. I'm so sorry that we can't be together in person the way we had planned more than a year ago, but I'm really, really glad that we could make this work thanks to technology, because this is such an important topic, especially right now. As we've already said, criminal justice is really on all of our minds this week, maybe even more than usual. Today, I want to talk about yet another killing, one that happened last year, right about the time that we were supposed to all be together for this talk. In a lot of ways, it really bears many similarities to these other incidents. But the death of Daniel Prude in Rochester, New York, also raises issues that are all too often overlooked about how in America today, we make mental illness a crime. So this morning, I'm going to tell you about what I've seen and heard about the criminalization of mental illness in this country. I'm going to talk a bit about how we got here and how this story fits into the larger picture of mass incarceration. And I'm going to talk about some of the ways that I think we can do better, including some lessons that I hope that we've picked up in this awful last year. So before I get to Daniel Prude's story, I want to start by giving you some very basic facts about mental illness and the criminal justice system so that you can all understand or begin to understand what we're really up against when we talk about this. Now, as Theresa mentioned in my introduction, the three largest psychiatric facilities in the United States are Rikers Island in New York City, the LA County Jail in Los Angeles, and the Cook County Jail in Chicago. So just in case you missed that, the biggest mental health care providers in this country aren't hospitals and they aren't clinics, they're jails. Now, I don't know how many of you have been inside of jails or inside of proper mental health facilities, but I want to be really clear that jails are really the absolute opposite of anything therapeutic. And that starts with the fact that the purpose of jails is punishment. It's not treatment, it's not cure, it's not care. Now, if you visit a modern day mental health care facility, or even if you just look at their brochures online, they'll be proud to tell you about the calm spaces that they feature and the mood lighting, the outdoor spaces and treatments that range from regular visits with a psychiatrist to a whole range of individual and group therapies. Now, jails, on the other hand, are loud. There's constant yelling, both by the officers and the people who are locked up there. There are gates and doors that are always clanging. There are bright fluorescent lights that are on, in some places 24 hours a day. Often the windows are either tiny or there are no windows, so that means that there's little or no natural light. Jails tend to be airless. In many cases, they smell unbelievably awful. It's this mix of unwashed bodies and dirty laundry and excrement. One psychiatrist described them to me as psychotogenic. In other words, that they cause psychosis. Now, as many of you know, people who are held in jails and prisons have a constitutional right to mental health care. They're the only group in this country that have that constitutional right. The problem is that care inside the jails and prisons is often less than stellar. Among other problems, it can be hard even to see a therapist or psychologist regularly. And yet, for so many people in this country, this is what we have for mental health care. I recently heard from a public defender in New York about one of her clients who has a long history of mental illness and substance use. He was arrested because he had allegedly assaulted somebody at the Port Authority bus terminal where he'd been living. And at the time of his arrest, he told his lawyer that he didn't want the judge to set bail, which in theory could have gotten him out of jail. He wanted to stay in long enough to do a substance use program. So in case you didn't get that, this man told his attorney he wanted to go to the jail on Rikers Island because he thought he could get treatment there. Now that's a problem. Now, of course, jails and prisons weren't designed to be healthcare facilities. And so maybe it's understandable that they're not very well equipped for the job. But unfortunately, they have plenty of clients. So on any given day, as many as a third to a half of the people held in these institutions have a mental illness. So let me just put that into context. There was a report that was presented recently to the Board of Supervisors in Los Angeles, and it showed that in 2019, there were around 17,000 people being held in the LA County Jail. Now, that number in and of itself is astonishing, but of that 17,000, of those, more than 5,500, were sick enough that they were being housed either in special mental health housing and or they were taking prescription psychotropic medications. And I have to say that some of the people with the most severe mental illness that I've ever seen are on the mental health floors of the LA County Jail. There's a man that I wrote about in my book who used feces to stick paper towels to the walls of his cell. There's another man I met there who had torn a piece of flesh out of his own arm minutes before I saw him. It's also important to remember here that the people who are in jail haven't been convicted of a crime yet, and they may never be convicted of a crime. In most cases, they're still sitting in jail only because they can't afford to get bailed out. It's also important to note that people with mental illness are less likely to make bail than people without mental illness. And those that do get the bail assigned, it takes them longer to come up with the bail and get out of jail than for other people. Now, you may have heard that the number of people in jails and prisons have been going down over the last many years. The problem is that the proportion of people with mental illness who are in them has actually gone up. In other words, even though the absolute number of people being held has dropped, a greater percentage of them have a mental illness. So what does that look like? In 2010, about 30% of the people held at Rikers Island in New York had a mental illness. By 2014, that number had gone up to 40%. And by 2017, it was up to 43%. And this trend has unfortunately held even as jails and prisons released large numbers of people at the beginning of this pandemic in an effort to try to limit the spread of COVID. So, for example, in March of last year, 44% of the people being held at Rikers were known to have a mental illness. So again, that trend has gone up from 43 to 44%. But by May, so 2 months after the start of the pandemic, the overall population at Rikers dropped by a third. And that's impressive that they were able to cut that population so much. But more than half of the people who stayed behind were known to have a mental illness. And on top of that, when you look at the people who got released from Rikers during that stretch, many, many more people in the general population got out than the people who were known to have mental illness. I should also add here that unfortunately, after that very impressive drop in jail populations, in many, many cities, they've gone back to where they were pre-pandemic. And it's still not clear what those numbers mean for people with mental illness. Now, this mental health crisis in our criminal justice system affects everybody, but it's especially pronounced among incarcerated women. The Bureau of Justice Statistics estimates that 75% of women in jail or prison have a mental illness. 75%, so that's 3/4 of the women who are held in our jails and prisons have a mental illness. Another study showed that 20% of the women in jails and 30% of those in prison had experienced serious psychological distress in the month before the study was done. And this has absolutely been borne out in what I've seen anecdotally. I visited Oklahoma, which has the highest rate of female incarceration in this country. And when I visited the women's prison there, the psychologist told me that 90% of the prisoners were getting some form of mental health care. So you could look at this as great, they're getting the care that they need. We can also say, this is terrible. What are these people doing there? Now, one reason for these very high rates of mental illness among women in the criminal justice system is that they are far more likely to have experienced things like sexual abuse, trauma, substance use, all things that are closely tied and intertwined with mental illness. And this, anecdotally anyway, that connection has borne out in conversations I've had all over the country, including with women here in Minnesota who have been in Shakopee. Now, the other thing that's important to know here, just to remember, is that in overall numbers, there are far fewer women who are locked up in this country than there are men. But women are by far the fastest growing population of incarcerated people in this country. And so if these numbers keep going up the way they have, and the percentages continue the way we've seen, we can expect to see many, many more incarcerated people with mental illness in coming years. People with mental illness, as you may have heard, are far more likely to end up in solitary confinement. There are many, many stories, and it's well documented, of people with mental illness who are punished with solitary confinement for behavior that's directly related to their disease. So a person acts out, a person gives officers a hard time, and they're sent to solitary. For those of you who aren't familiar with the practice, it is an absolutely brutal practice where people are held without human contact in rooms that are often smaller than the average bathroom. I've talked to men who describe being able to put their arms out on either side of them and touch both walls of the room. Solitary confinement is so harsh that it's known to exacerbate symptoms of mental illness in people who have it. And it can even trigger symptoms of mental illness in people who previously didn't have those symptoms. And adding to this already very surreal practice is the fact that if you break the rules while you're in solitary, and those rules are often just capricious and difficult to follow, especially for somebody who's dealing with mental illness, breaking those rules will often lead to even more time in solitary. Now, we have all heard and talked about the racial inequities of the criminal justice system. By some estimates, I think it's 1 out of every 3 Black men and 1 out of every 6 Hispanic men who were born in 2001 will be arrested over the course of their lifetimes. And those statistics are shocking and awful to me every time I hear them. But I also want to call your attention to an even more shocking statistic that often gets overlooked. And that's that for people with mental illness, and that of course includes people of color with mental illness, the estimate is that as many as 1 in 2 will be arrested over the course of their lives. Now, police shootings, of course, have been on everybody's mind this week. Excuse me. And since at least 2015, roughly 1 in 4 fatal police shootings have involved a person with mental illness. That's 1/4 of fatal police shootings that involve a person with mental illness. And it's important to remember, too, that that number only includes fatal police shootings. So it doesn't count when the, excuse me, it doesn't count when the police shooting where the victim survives. And it's not talking about times when a person dies at the hands of the police by other means. So that brings us to the story of Daniel Prude. You may have heard something about it when it came to light last summer. And as I said earlier, in some ways, it's surprisingly similar to George Floyd's story. But it also raises issues about how we treat people with mental illness. So just to remind you, it was late March of last year. The country was just going on lockdown because of COVID, when Daniel Prude ended up getting killed by police officers who held him face down to the ground. What you might not remember about this story is that earlier that same night, Daniel Prude was taken to the hospital because he had been threatening to kill himself. And the doctor on call at the hospital had decided that he was okay and sent him home to his brother's house. And it's a scenario that I've heard many times, where the person is taken to the hospital in crisis and they end up being discharged, often with terrible, terrible outcomes. But I want to point out, too, that the police knew all of this when they went out to look for him. So that night, after he'd been in the hospital, Daniel Prude was sitting at his brother's house in Rochester. And suddenly, he asked his brother for a cigarette. When his brother got up to get the cigarette, Daniel Prude jumped up and ran outside, wearing nothing but a tank top and long john pajama pants. He wasn't even wearing any shoes, even though it was snowing out. Now, Rochester's weather is similar to what we have here in Minnesota. So the end of March is cold and damp. Daniel Prude, as we've just determined, was in the middle of a mental health crisis. It was a mental health crisis bad enough that he had gone to the emergency room. And he was also high on PCP, which we'll come back to. So when he ran outside, his brother was obviously very, very worried. And so his brother did the only thing he knew to do. He called 911. Now, I want to pause here and say, why is that the only option? Why wasn't there somebody else that his brother could call in this moment? But knowing that it was his only option, Daniel Prude's brother tried to do it the right way. And so, as family of people with mental illness are always reminded to do, he made sure to tell the dispatcher that his brother had talked about suicide earlier that day, that he was worried that he might be heading toward the train tracks that are behind his house. And then the brother, too, went out to look for Daniel Prude. So the call went out on the police radio saying all of that. And over the next 20 minutes or so, the police were dispatched. They went out and tried to find Daniel Prude. Daniel Prude, meanwhile, was wandering around, acting incredibly strangely. One bystander reported that he had been biting at trash cans. He was also shown on surveillance cameras that he had thrown a brick into a store window, through the window of a store. And he actually went inside and wandered around, even though he didn't end up taking anything. And along the way on this strange journey, he somehow managed to take off the few clothes that he had been wearing when he left the house, so that by the time the police found him about a mile from his brother's house, he was completely naked. The police saw him. They told him to get down on the ground, which you can see in the body cam footage was damp because it had been snowing. And Daniel Prude did that without any argument. He lay down on the ground, and the police handcuffed him behind his back. Now, the basic police academy in Monroe County, which is where Rochester is, takes 6 months. Of that training, 3 weeks are dedicated to defensive tactics. 20 hours, so let's say less than 3 days, are spent in a class called the Fundamentals of Crisis Intervention Skills. And that is the only training that recruits get in mental health. And until a few years ago, those 3 days were actually more like 2. It was 14 hours of that training that was mandated. I don't need to point out to you that that is not a lot of training to deal with true mental health crises. So the officers who responded to the call that night really didn't have any proper training in how to handle a person like Daniel Prude, who's in a crisis, and they're worried about it. One of the officers on the scene warned the others that Daniel Prude was likely on PCP. He later told investigators that he had seen people who had been on drugs, particularly PCP, acting erratically, and that he was worried. Even so, the officers talked about making what's called a mental health arrest in New York. So this is what had transpired earlier in the day. It's effectively a civil arrest that allows the officers to take the person to the hospital. And one of the officers even went back to his car to start writing up the paperwork for that. But in the meantime, Daniel Prude started getting more agitated. Not surprisingly, he's cold, it's dark, he doesn't know what's going on, he's naked again and handcuffed. But he started trying to sit up off the ground. He also told various people that he had COVID. So again, it makes sense that the officers would be nervous here. Remember, this was back when we didn't really understand how COVID was transmitted. It's before there were masks. It's before, just before the vaccine for sure, before we understood how it worked. At one point, you hear on the body cam footage, you hear one of the officers talking about going back to the car to get hand sanitizer. At the same time, on the body cam footage, it's very clear that there's still snow coming down. You can see it in the light of the officers' flashlights. And Daniel Prude is still lying naked on the cold, wet asphalt. I learned recently that the squad cars in Rochester apparently don't carry blankets as a matter of practice. And the ambulance, sorry, I don't know what's going on today. The ambulance, which pulled up soon after the police, did have a blanket on board, but nobody offered one to Daniel Prude. And nobody even offered him a jacket. Instead, when Prude started spitting, the officers decided they needed to put a spit mask on him. These come in various forms, but the basic idea is a mesh covering designed to keep a person from spitting or biting. And in this case, it was essentially a hood that went over his whole head. Now, it must have been really, really terrifying to have that spit mask put on, especially if you were as disoriented as Daniel Prude was. And after the hood was put on him, he kept getting more and more agitated. And he kept spitting inside the mask in the direction of the officers. At a certain point, he started doing what appeared like he was trying to stand up. And 3 of the officers took Daniel Prude to the ground. They later justified this to investigators as that they had occasionally seen suspects escape, even when they were already in handcuffs on the ground. And they said that they said that a handcuffed person could still have hurt an officer, even if he was handcuffed. A report from the state attorney general that was released later pointed out that there was room around where Daniel Prude was lying that the officers could have theoretically moved out of his reach without having had to restrain him further. So, on the one hand, we have Daniel Prude, who is getting much, much more agitated and upset. And on the other hand, we have the police who are getting more nervous, which I don't have to say is a bad combination. At this point, the officers warned Daniel Prude that if he didn't calm down, they would have to tase him. And then they pinned him to the ground. A few minutes later, the officers realized that Daniel Prude wasn't breathing, and that he had no pulse. So they started chest compressions. And after almost 20 minutes of CPR and other interventions by the officers and by the EMTs and firefighters who by this point had arrived on the scene, they did manage to get a pulse back. They took Daniel Prude to the hospital, back to the hospital where he had been earlier that evening, but he never regained consciousness. And after a week, he was taken off of life support. The medical examiner in Monroe County ruled the death a homicide caused by complications of asphyxia in the setting of physical restraint. The officers, as in so many of these cases, were never charged. The outcome of Daniel Prude's story is, of course, shockingly similar to what happened to George Floyd just a few weeks later. But I want to talk about how in so many cases, in so many parts of his story, it points to issues that go well beyond the immediate issues of policing. As New York's Attorney General said later, Daniel Prude was in the throes of a mental health crisis, and what he needed was compassion, care, and help from trained professionals. And tragically, he received none of those things. We failed Daniel Prude, and we regularly fail people like him. So I want to go back a little bit and put Daniel Prude's life into context before this point that brought him to all of our attentions. His life had already been pretty rough up to this point. He'd grown up in public housing in Chicago. He'd bounced around among jobs at warehouses and factories. He had a brother who died in a car accident when he was just 11, and another who was shot and killed in a murder that was never solved. And then in 2018, a nephew of his had shot and killed himself while Daniel Prude was home in the apartment with him. Daniel Prude, people pointed out, had a long list of arrests up until this point. They were mostly for low-level crimes, things like drug possession and driving without a license. And as you might guess from the charges, he had also struggled on and off with substance use. I should also point out that we don't need to look any further than the events of last weekend to remind us that interactions with the criminal justice system itself can be traumatizing. And that's true whether it's a routine traffic stop or the strip searches that prisoners are so regularly subjected to. There's a very strong overlap between mental illness and substance use. About 3/4 of people with mental illness who end up in the criminal justice system also have a diagnosed substance use disorder. And people often use substances, as you know, whether drugs or alcohol, as a way to self-medicate mental illness or mental distress. And in fact, that overlap between mental illness and substance use is one reason that so many people with mental illness get swept up into the criminal justice system. It also, of course, means that one way to have fewer people with mental illness in the criminal justice system would be to charge fewer people with substance or drug-related crimes. I don't know if Daniel Prude ever sought treatment either for his mental health or for his substance use. I do know that it is very hard to access mental health care in this country. And in Chicago, that's true just like the rest of the country. Several years ago, Chicago actually shut down several of its community clinics, which has made it even harder to access there. The other problem is that even when there is mental health care available, there aren't nearly enough providers of color. There's a man in prison here in Minnesota, a Black man with serious mental illness, who told me that his number one complaint about the mental health care he gets inside prison is that there aren't any counselors who look like him and who can understand him for who he is. That lack of mental health care is a really important piece of this problem. but it's not all of it. There's a widespread misconception that the crisis of mental illness in our criminal justice system was caused by the closing of the state psychiatric hospitals that started in the 1950s and 1960s in this country. In other words, you'll often hear, and you may have already heard this, that when the state hospitals closed, patients were dumped out on the streets with no mental health care. And the result, as the story goes anyway, they turned to crime and then ended up in our jails and prisons. It's a great story. Unfortunately, it's only that. It's a story. Part of that is that there are statistics that make it look like this story should be borne out. If you look at the statistics about the increase in our jail and prison populations, they started going up dramatically right around the same time as the state hospitals were closing. So the number of people who were living in state psychiatric hospitals went down dramatically at the same time. And it's a tidy story too, because if the problem is simply the result of not enough inpatient beds, then we should be able to solve it very easily by building more beds. But if you take a closer look at it, there are a number of signs that this is not, in fact, the case. Among other things, the residents of those state psychiatric facilities back in the day were largely elderly, female, and white. And as we all know, the population of jails and prisons today are predominantly young, male, and not white. So we haven't just transferred one population, the same population from one place to another. And another indication is that the patients in the state hospitals were overwhelmingly diagnosed with schizophrenia, while the people in our jails and prisons today have diagnoses that are much, much closer to what we see in the general public. So it's not that the lack of psychiatric care drove the increase in incarcerated people with mental illness, but rather the problems in both of those systems are shaped by many of the same factors. So there's a lack of resources, there's a lack of political will, at least on the right sides of the issue. And above all, there's a lack of understanding of what the people in both of those systems really need. So where does this leave us? Certainly, we do need more mental health care in this country. That doesn't necessarily mean many more inpatient beds, although we certainly could use some more from what I've heard from psychiatrists and other people in the field. But we also need more mental health care in our schools. We need more outpatient care that would make sure that people didn't need inpatient care. And we need more step-down programs, residential treatment facilities, and really a broader range of options for people to get the mental health care that they need at the level that they need. At the same time, many of the things that we talk about in the realm of criminal justice reform would also help us reduce the number of people with mental illness who end up in the criminal justice system. And that makes sense because, as I said, much of what drove up the numbers in the first place, at least to the levels that we see today, so things like mass incarceration and the war on drugs, those also drove up the number of incarcerated people who have mental illness. So that means it would help if we reduced the criminal system overall. In other words, if we arrested fewer people for the so-called low-level crimes, things like what Daniel Prude had been picked up on, things like drug possession or disorderly conduct. And at the same time, we can't forget that for the people who do end up in jail and prison, regardless of all of these efforts to do otherwise, we need to make sure that we're providing better mental health care to those people so that they are in a better place when they come out, not a worse one. For much of the last year now, we've been hearing talk about defunding the police. But when it comes to mental health, I think that it's important to take a step back and ask the question, why are police being asked to respond to mental health emergencies? for the most part, the police that I've talked to and the police that we hear from, they don't want to be responding to those calls either. Like the officers in Rochester, most of them aren't trained to do it. So what can we do instead? There is some hopeful movement on that front. Many cities now offer some training, at least to some of their officers, about how to respond to a mental health crisis. Some, like the Special Mental Health Unit here in St. Paul, will send a social worker out with a police when there's a mental health call. And other cities, like Eugene, Oregon, have even taken it a step further by dispatching only a mental health worker instead of a police officer to most cases. I talked before about how early on in the pandemic, cities and states really across the country were making an effort to release large numbers of people out of the jails and prisons as a way to prevent the spread of the virus. And as I said, that effort ultimately largely failed, and jail populations in particular have largely returned to what they were before. I've heard similar stories out of state prisons that most of them didn't do a great job of getting people out. But I still really hope that the experience of this past year, the fact that so many jails did manage to reduce their populations even temporarily, and that prisons were thinking about cutting back on their populations, that this experience has forced us to reconsider who really needs to be locked up. Why are we locking them up? And how long do they really need to stay there? What are we accomplishing by keeping people locked up for so long? I think that the other thing that the pandemic has opened our eyes to is the need for equity, and the need for equity in healthcare and in other places that we may not have thought about it so much before. So if you think about what's happened with the vaccine rollout, for people who have internet access and who are tech savvy and so on, it's been much, much easier to find appointments to get a vaccine. The people who have transportation can get to those appointments, even if they need to drive halfway across the state to go get it. And so I think we need to think about that kind of equity and equity in access, certainly for how we offer mental health care, but for other things related to what we've been talking about today. So even how hard do we make it to visit a loved one who's in jail or prison? If you don't have a car or you don't have an ID to get in, all these things, we need to think about how that's affecting us. I've talked about a lot of really upsetting points today at an upsetting time in our country. I want to say that maybe the most hopeful thing that I've heard and that I've been hearing now for years and years is that when I talk to people on all sides of this issue, so that could be people with mental illness who are caught up in the system, could be the defenders, it could be the prosecutors, judges, police officers, corrections officers, family members of those people, what everybody agrees on is that what we're doing right now is not right, and that we need to change it. And so I'm hopeful that there's the will to do it, and we just need to figure out how. Thank you for listening.
Ms. Roth, thank you so much for your presentation, for the profoundly important information that you've supplied to us, and for the what you have brought to bear and the perspective and thoughts for change that you've provided. So thank you. It's we don't get to in Zoom time. We don't get to give you proper applause, but it's there. It's there.
Thank you.
So we have time, there's some pretty generous time actually for Q&A. So I'm going to ask folks, already starting to see some questions or thoughts that you have about specific topics. So I'm going to turn it over to Dr. Gunatilaka to start to bring some of those forward.
Thank you, Dr. Libby. Folks are still posting questions. Ms. Roth, you've given us a lot to reflect on. Thank you for that. So let's see. Oops, this is moving very quickly. Give me one sec. So John Becker is saying, would like to hear Ms. Roth talk about mental illness defense standard that is used around the country. Minnesota has one of the highest standards with our Northern standard. I wonder if you care to speak about that?
Sure. You know, it's funny, for all mental illness interacts with the criminal justice system, there are really only 2 points on the legal side when there's an interest in somebody's sanity. So one is at the time of trial, you have to be sane enough to understand the charges against you, to understand the role of the people who are judging you, and so on. So that's one piece that refers to, it's called competency to stand trial. The other time is at the time of the crime, or at the time of the alleged crime. Did the person know what they were doing? And that latter is something that plays really large in, I want to say, the popular imagination, but when you actually look at the numbers, it very, very rarely comes into play. It's a very, very small number of cases where the attorneys will actually ask for an insanity defense. In other words, that the person was too sick at the time of the crime to know what they were doing. And in those few cases where that plea is actually made, it's an even smaller number where the person is actually granted it. And it's a complicated question. I think, should the person, I think there are times when absolutely a person, we should say this person didn't know what they were doing and can't be charged. I think that the bigger question is maybe, why are so many people who have mental illness, who clearly have mental illness, getting pulled into the system to begin with?
Correct. Yeah, absolutely. Absolutely. Okay, so another question. I'm actually not sure who posted it. Dr. Teresa Libby said that we got this earlier on. The question is, what have other states done that has been successful in getting the attention and resources from their government and legislators for this crisis? But I also like to add to that, perhaps if you could talk about maybe if you could go beyond, other states and maybe look at other countries who have successfully done this.
Unfortunately, our country, when it comes to both criminal justice and to mental illness, is a standout, and not in a good way. So I'm sure you've all seen the charts that show, incarceration rates in the United States are here, and the next closest competitor is maybe half as many, and it drops down from there. When we look at Scandinavia, which of course is often held up as a model for these things, you can see on both sides that they do better. So on the criminal justice side, they are arresting and incarcerating far fewer people to begin with. And at the same time, with their universal health care, they're doing much better on the mental health side. So in the course of my research, I actually visited one of the prisons in Norway, and I met the psychologist who ran the mental health practice. And there were a couple of things that really stood out to me there. One was that I asked her how often it was that somebody would come into her office and get a diagnosis of mental illness, for the first time when they showed up in prison. And that's a fairly common event here. And what the psychologist there in Norway told me was that it was extremely rare, and that it was only on the very occasional times when somebody had been on the streets for so long or so caught up in something like very, very serious substance use that they would not have already seen a doctor for this. And so what that meant is that you could go into the health records and see this person had a breakdown when he was 18. This medication worked. This one didn't. This person had another breakdown when he was 25. And it made it so much easier for the clinicians to be able to treat it. I want to make one other point that really struck me there was that in many, many places where I visited here in the United States, when you go to get the mental health care, and this is already, the person who's gotten it has already gone through a whole series of, requests and waiting and so on, but you are accompanied to see the clinician by an officer, or the clinician comes to see you and will talk to you even through the cell door, so a thick steel cell door. And I remember going into the mental health clinic in this prison in Norway, and it was like any other doctor's office. There was a rack of magazines on the wall. There was a little bowl of candies on the table in case you needed something while you were waiting. They even, as I recall it, had clinicians who spoke multiple languages so that if Norwegian wasn't your first language and you didn't feel comfortable talking in it, you could speak in your native language. So much to learn from other places.
Appreciate that. So it sounds like you're saying it's kind of built into the system. This is how to work with individuals who have mental health concerns. And
to treat them as the people that they are. I think one of the big differences there is that when somebody is incarcerated in Norway, from day one, the idea is to prepare them for the day that they get out. And that goes all the way through their system, whether it's facilitating visits with their family, even overnight visits with the family, or job training. They don't even wear uniforms because, as the warden told me, he wants people to look in the mirror and see a man, not a prisoner.
Yeah, thank you. There are a few questions from students and educators. So I believe this is from an educator. We are a university campus. As educators, how do we create impactful change transformation in curriculum and practice as it pertains to this topic? What are tangible and practical ways to engage in praxis of people working with students and new professionals? And I believe this is probably will apply to mental health and social work and all the human service field as well. We know that this topic is intersectional and historical, race, class, ability, gender, as you discussed with Daniel Putz. So I think it's more of a statement, but I'm wondering if you want to say, more about that.
It's a very good point. I think that we do need to think about it not just in one piece. It's not just the criminal justice system. It's not just the mental health care system. It's a whole picture. And absolutely race and class and gender and ability and all these things fit into it. And so we need to think about, how are we best serving the needs? How do we make sure that we understand what people are up against? How do we make sure that we get the people what they need to best serve them?
Absolutely. So this question, in your time of research, how often is it that you see culturally specific and responsive care being provided within the prisons in the US?
As I said in my talk, the people who are held in our jails and prisons are the only group of people in this country who have a constitutional right to health care. Mm-hmm. And that constitutional right means that you should be getting care in the jails and prisons that's equivalent to the care that you would be getting on the outside. There are a couple of problems with that, including what we talked about earlier, that we simply don't have enough mental health care even on the outside. But there's also the problem that getting quality mental health care in our jails and prisons is very, very difficult. It's difficult for a number of reasons. We often hear that the people who are hired as psychiatrists and therapists and so on inside the jails and prisons are people who couldn't get jobs anywhere else. I have absolutely heard stories of terrible examples of practitioners on the inside. I think it's also important to say that I have met some phenomenal doctors and psychologists and therapists who really made it their life's work to work with this population. But I think, unfortunately, we're not even at a point in most places to think about culturally specific and culturally responsive care. We're just at a point where we need to think about how do we get enough care and quality care. And of course, having culturally specific and culturally competent care is critical. But right now, we just don't even have enough of that care, of any care. I will say that in some places, I'm thinking of Washington State in particular, but in some other systems as well, there is at least an effort to make the mental health care more similar to what you see on the outside. In other words, to flag particularly difficult cases and have really convene a team, which is what they do in Washington State, convene a team of all the people who are caring for that person. And so to compare notes and make sure that you're moving forward on giving them that care.
Yeah. All right. Thank you. I think you talked a little bit about this, and see if if you can add a little bit more. Some law enforcement agencies in Minnesota are using a co-responder model to respond to mental health crisis. I remember you talking about, some sense a mental health professional as well, with an officer and a mental health provider together to assure safety and provide an immediate connection with the mental health professional. How do you feel this model will affect the acute mental health crisis for individuals?
I'm sorry, I missed the last. How will it affect the?
How do you feel this model will affect the acute mental health crisis for the individual?
I mean, I hope that having a person who's trained in responding to a mental health crisis, trained in de-escalation, trained in being a decent human being whose point is to help this person out of the place they're in, has to help the crisis. It's, of course, complicated. If the person is having the crisis on a busy city street, how do we ensure the safety of the people who are around while also taking care of that person? But I think that there's no question that having a trained mental health professional respond to a mental health crisis rather than having a police officer who's trained to respond to crimes and criminal activity respond to that crisis and have to try to figure out how to take care of that person.
Absolutely. So just to remind folks that, we still have time for questions, so please post your questions. I believe this is from a student. So they're asking, what can current grad students, so I believe they are probably in the mental health or corrections or service, human service field, and beginning professionals in mental health addiction to get involved? How do we get started working with the incarcerated population? So I believe that probably we could take that question into the general public as well. So what can we do individually as a student, as a community member, either together or as individuals?
I think that one of the things that we have done with mass incarceration in this country is push that whole question out of sight and, in theory, out of mind. And so even remembering that there is a huge portion of our population that is incarcerated, and that these are people is an important start. I think that there are many ways to reach out to that population. It, of course, varies city by city and state by state, but there are ways that one can volunteer and go into the facilities to teach or lead workshops. I think there's also a tremendous need for supporting people both before they get into the system and when they come out, and acknowledging that in many contexts of social service, there are ways to engage and talk about what's happening in the criminal justice system. So how, there's a population who often is coming back and forth. So, the person who's the patient in the state hospital today may well be the person who's the patient in the state prison tomorrow. And so engaging the populations in that way.
Absolutely. I'm trying to find a question, as you probably need a break from talking as well. Okay, so we have, I think it's more of a statement, but see if you could say something about it. In social work, we have to work on the tendency towards clinical diagnosis, medical model of people who have been victimized by racist systems. There is no diagnosis in the DSM-5, which is the current assessment book for psychiatric conditions related to systemic racism. Unless changes are made, reliance on mental health systems will not result in substantive changes. So, any thoughts on that?
It's a really interesting point. I think that we as a society have a tendency to like diagnoses and labels for things. And I think in some cases, so in the instance of, say, health insurance, it's very useful to have a diagnosis that you can attach a code to and then bill for. And certainly that's one of the problems we see in mental health care, is that it's hard to bill for certain things. And it's one of the reasons that that discipline is so poorly paid. I think in other cases, having a diagnosis and the need to have this diagnosis complicates things. And in fact, in some parts of the criminal justice system, we're starting to see a move away from that, particularly when you talk to people who, for example, defend people who are faced with the death penalty. There's really been a move away from saying this person has schizophrenia or this person has a substance use disorder, but rather looking at their abilities and their disabilities. What are they able to do? What are they able to comprehend? And I think that maybe there are ways, if we think in that framework and sort of outside of that box, there are ways to include the effects of things like systemic racism. Mm-hmm. I also hope that the awful, awful events of this last year and of course before that are making people more aware of the ways that things like systemic racism do affect people, even if it's not something that's as easy to put in a box as say, schizophrenia or bipolar disorder.
Absolutely. Yeah, I hear you. One of the questions is asking about you described what happened with Daniel Prude. So they're asking, should the medical field be more responsible or somehow involved for some of these cases?
I think that, one of the things that I found most upsetting about Daniel Prude's story was the fact that he had already been in the hospital the night he died. His brother and his sister-in-law were worried enough about him that they had sent him to the hospital. And in fact, there had been a mental health warrant issued for him that day. That was what got him to the hospital. And so it's called, comes under different names in different states, but the idea is the same, that it lets you effectively arrest somebody for the purpose of getting them to the hospital. And yet he was released that night. And it's a little bit tricky. I've heard many stories of people who are sent to the hospital. Everybody agrees they need to go to the hospital, but by the time they get there, somehow that mental health care provider decides that they don't fit this very narrow definition of being ready to hurt themselves or hurt somebody else. And so they are legally required to send them home. So there's a young man that I write about in my book who was very psychotic. His mother, again, called the police because that was the way to get him to the hospital. And this young man was smart and informed enough to say he wasn't going to hurt himself. He wasn't going to hurt anybody else. And he ended up being shot by a police officer after he was released. There's somebody else that I followed for a long time who was in fact picked up and arrested and spent more than a year in jail the same day or a day after his mother had gotten a mental health warrant so that he would be put into the hospital. The problem where it gets complicated is that we want to make sure that we protect the civil liberties of people with mental illness. We don't want to be able to stick somebody in the hospital against their will. And so, yes, I absolutely would like to see the physicians and other professionals taking a harder stance so that we could prevent these awful outcomes. But I think it goes beyond the medical profession. We have to look at the legal system. How do we decide who's making the judgment, who's making that decision for us?
Absolutely. In your opinion, do you think the way we feel, or perhaps let me rephrase that, in your opinion, how we treat these individuals who has mental health challenges and needs mental health care, but also gets criminalized within the system, do you think that is more of a reflection of a society that we live in, reflection of the society that we live in? And if so, how, it seems like it impacts the laws and the policies that we rely on the system to enforce, for lack of a better word.
I mean, certainly, if we don't have enough social services, whether that's mental health care providers or anything else, school services, all of these things that we need, we end up turning to law enforcement to solve those problems. And so, again, I come back to, why is it that the only place that Daniel Prude's brother had to call when he's worried about his brother, why is it that the only option he has is to call 911? And I think that we've somehow decided that that's how we handle things. And I think it's with the results that people end up getting criminalized by, if you're calling the police because somebody's in a crisis, almost by definition, you're saying this crisis is a criminal act in some way, right? Not legally, of course, but sort of conceptually. And I think that we also have over-criminalized everything so much, and we have ended up putting so many people into the system that's become sort of our default fix. It's quick, it's easy, get them off the street, get them out of sight and out of mind.
I hear you. There's lots of chat that's going on. More so statements. And it seems like you're talking about it's the stigma also that contributes to this fear and then, think, okay, this is my only option. So
well, I think the stigma is, I'm sorry, go ahead.
Go ahead. Yeah.
I think that the stigma is very real. I think that we wrongly connect mental illness with violence. We know, looking at the studies, that people with mental illness are far more likely to be the victims of violence and of crime than to be the perpetrators of the violence and the crime. And yet the assumption is always, this person is going to be dangerous. We need to watch out for this person. I think the other piece of it that is that stigma that you talk about. There's a reluctance to seek the healthcare. There's a reluctance to talk about it. I still remember there's a man that I followed for a long time in New York who was diagnosed very early on with schizoaffective disorder, so a form of schizophrenia. But I distinctly remember his mother telling me that he had been diagnosed with bipolar disorder. And when I figured out that she had told me something completely different, I finally realized that it was somehow less shameful for her to tell me that he had bipolar disorder than to say that he had schizophrenia. And I thought it was so interesting because it was like gradations of stigma. But certainly nobody wants to say, my child has mental illness or my sibling has mental illness. And I think that extends too to the seeking help. People are reluctant to seek help because that's acknowledging that there's a problem, that there's a need. I hope that this past year, it's something else that I hope has come out of this awful, awful last year, is that mental health has really come to the front, and people really understand that mental health is something that affects everybody. And so that I hope it will help change people's perceptions of what it means to ask for help.
Absolutely. I think you.
We have time for maybe. Yeah, we have time for maybe one more question.
Yeah. I was going to say that, I think Ms. Roth brought up a really good point about the gradation of how the shame. Absolutely. But it sounds like you're saying perhaps we need to begin with looking at this as human experiences and starting there.
Well, certainly if we look across cultures and across the ages, what we've defined as mental illness is not consistent. There was a time not so long ago when the DSM included homosexuality as a mental illness. To say that today in most places in this country anyway is a ridiculous statement. And so I think we do need to think about that when we talk about mental health. How do we define it? What does it mean to have a mental illness? What does it mean to be mentally ill?
Thank you, Ms. Roth. I think that's we are at good time, Dr. Libby, for questions, Q&A.
Yes, absolutely. So in just a minute, we're going to go, we're going to take a break and resume at 10:25. But before we do that, I just want to thank you so much again, Ms. Roth, for being here with us today, to sharing what you've learned and your thoughts about it. And can we unmute the crowd? Can we unmute everyone and give people a chance to applaud? And I think Brian and Jody are both working on this.
They can unmute themselves.
Mm-hmm.
Oh, people can now unmute themselves. All right, great. So all those who wish to, would you please take a moment to unmute, and can we applaud and say thank you so much for Dr. Roth. So appreciate it. And glad that this that your talk is going to get out there as well on through NPR, as well as on our our YouTube. So thank you again. Best wishes.
Larissa, I didn't hear Tonya Baxter applauding, so just want to check.
See, one of the many things I love about you, Raj, is that you're a troublemaker. All right. Great. Okay, everyone, 10:25 is when we'll come back from the break. And at that time, Dr. Raj will give us our charge that we're going to take into our circles in the breakout rooms. So enjoy the break and see you soon. And thanks for all your acknowledgments in the chat. I'm hoping you're seeing those, Alisa. All right, great. See you soon.
The numbers to the ceiling. Yes, reach. Let your pipeline to your lungs is all cleared, and breathe in. Breathe out. Yes, right? Yes, and everybody appreciate Arshini for that amazing questions and managing that process. This is so fast. The chat moves, so we appreciate you just keeping up, right? Natalie Martinek, how you doing, Natalie?
I'm good. How are you?
I am peachy.
I'm a former student. I graduated in 2016, so I'm thankful I can join this because I live in Texas now.
Tejas, where in Tejas? Were you affected by the freezing weather?
Thankfully, I wasn't directly affected. I live in the Fort Worth area, so where everything was kind of happening too. But gratefully, the only thing I had to do was boil my water, which was the least of a lot of people's worries. So it was crazy. Growing up in Minnesota and then experiencing freeze down here, people are not sure what to do with themselves.
Oh yeah. Okay, y'all. Stop spotlighting. Told y'all no. Okay. I'm like, what is that ugliness? Okay. Miss Omar, how you doing?
Good, thank you for asking. How are you?
Hey, you. Hey, you.
I'm sorry. How are you doing?
Who is that wonderful, beautiful voice? Share that love with us. There you go. Wow. Yeah. We are going to get to see this amazing voice. Says we wait for that wonderful voice to come on. So I want to appreciate, right, our speaker, amazing presentation, right, such wisdom that was shared. It's often, right, we don't hear the cumulative impact of the policies and procedures of the 80s and the 90s and how it has impacted mass incarceration, right? And targeted incarceration. As some of the scholars these days say, you know, we can't just talk about mass incarceration. We have to be much more conscious about calling it targeted incarceration, right? Targeted incarceration is about who are the people who are being incarcerated specifically, right? Mentally ill communities are affected. Trans communities are affected. Black and brown bodies are affected, right? So much of that targeting is going on systematically, right? So appreciate that, appreciate the knowledge, the wisdom, right? The information that has been shared with us. So as you come in, right? As you come in, I want to invite us to just kind of take a minute to think about all of the things that we heard, right? At a cognitive level, right? At a cognitive level. And then, right, let it resonate with your heart space, right? Let it resonate with your heart space. And also, right, recognize how our body is showing up. When we hear all of this information, right? Sometimes we want to numb ourselves, right? We just don't want to, we are overwhelmed. And at times we just want to react, right? We want to react. And other times, right, when we're able to stay focused with our body and name where our body and emotions are, right, then we are able to reflect. And we want to invite you today, right, to own all of that, right, to numb, to react, and also to reflect. So we want to invite you when you go into your breakout sessions, right, to talk about, is it numbing, right? How it's affecting you. Sometimes this information, right, has a face. It's no longer just numbers. It has a face. It has a heartbeat, right? And all of a sudden, everything just becomes so, right, critical. We want to invite you to talk about that, right? How did you receive this information? Is this just an intellectual exercise? Is it an emotional, right, engagement? Right? In what ways, right, is it emotionally affecting you? I want to invite you to talk, share, right, in that process, right? Honor each other's voices when you're in your breakout sessions, right? If one person is talking, let the rest of us listen and learn from each other, right? And then the next person, he or she or they, can call on another person in that room, in that space, right? We want to honor each other's voice, respect, right, our perspectives, right? And unless the perspectives that are being shared are right, demeaning and dehumanizing, then I want to invite us to, right, invite myself or Teresa into that group, right? We love to come in and figure out how do we, right, continue staying in this group and repair the harm. But until such time, right, you are all amazing people, right? I want to invite you to share your thoughts, feel your thoughts, understand your body. After sharing that first part, right, I want to invite you to reflect and work on resolutions together, right? What does a reformative justice work look like given this epidemic of violence that are perpetrated on communities that have mental health concerns, right? How do we, right, come up with solutions, right? At a local level, at a state level, at a national level. What can we contribute, right? And as a group, we want to invite you to come up with some solutions, right? Some thoughts on and some deep reflections. Together, right, we want to move from that critical thinking to critical consciousness. So I want to invite you to think about, right? Let us move from critical thinking, right? So 2008 education, right? Y'all can laugh, right? So 2008. 3008 education requires us to be critically conscious, right? So let us come there. So with that, I want to, if there are any questions, right? And please raise your hands, we'll answer. Meanwhile, Brian is going to put, no? Who's doing it?
I've got it set up, Raj. I can
Okay.
open the rooms whenever you're ready.
Okay, and then when you see the room appear, click on it to join it, right? Jody Bentley is doing it, so y'all give it up for Jody Bentley, the one and only, right? She does everything on campus, right? So I will see y'all, right? I'm hoping that I can float around, and then also when we come back, we'll share some of our thoughts. So take notes, right? Create your own document. You can even, we're hoping that we can let them share their Google Docs or whatever they are starting. So love y'all. Thank you.
Raj,
So-
if I may, just to let people know, we'll be coming back at 11:25, so people have about 50 minutes.
Yeah. And we'll give you some like time check alerts. Okay?
All right.
Okay. See y'all soon.
I didn't accept my invitation because Raj talked about us floating, but he went off into a room. So I'll.
I think if he comes back to the main room, I can move him to another room if he wants to go to another room.
Mhm.
And I could do the same for you. Would you like to know where he is, Larissa?
Sure, that's
So
fine.
we have 15 rooms, so that there are between, in theory, 8 and 10 people
Mhm.
in each room. Not everyone is joining. So I can see on my breakout room progress list.
Mhm.
Room 1 so far has 5 people, and 2 has 6 people, and 3 has 2, 4, 6, 8. Darshini's in that one. Yeah, so it looks like they're running around 6, 8 people a room.
Okay.
Some are a little smaller, depending on who's joining or not. So I don't know how to share this list with you.
Actually, I can see it.
Oh,
I'm
you
looking at
can?
it. Mhm.
Okay, great. So
Yeah,
so you can just hover around join and join wherever you want, right?
I believe so. I've done it before.
So if you're looking at the breakout rooms at the
Mhm.
top, there's of each room banner where it says room 1. On the right, it says join. A host or a co-host should be able to just click that and join that room.
Got it. That's funny. That's right. That's what I've done before. Yeah, there we go. I'm getting it.
Yeah.
First, I thought I wasn't getting it, but I am. Brilliant. Okay. How about you? You need anything from me?
I don't think so. Brian and I will just continue to watch admissions, and if people need to be placed in a room, if they're not already assigned to a room,
Yep.
we'll assign them. And then, there may be people who are just stepping away for a minute.
Sure.
It's hard to know.
Well, I think I'll do what I do in Founders Hall and New Maine, which is float a little bit from room to room and
Sure.
see how things are. So great. Thank you, Jody.
You're welcome.
You and Brian are being amazing today, as always.
We're figuring a few things out we haven't had to figure out before.
Yeah,
That's
not a
all good.
surprise. Yep.
Learn through practice.
The largest number I saw was 220.
Me too.
You assigning the folks who just came in. You want me to do that?
I can't tell who they are on my screen.
All right, great. I got it.
Okay.
They're at the very top of the breakout rooms.
Oh, okay.
So I got those two.
They just show up above room 1.
Mm-hmm. Yep, there's a category called unassigned.
I'm not seeing it on my list.
Oh, weird.
Yeah, it is weird because Brian just made me host.
Mm-hmm.
So it's weird that you have that capacity and I don't.
Mm-hmm. Do you see it now? There is a person who's unassigned.
Oh yeah, now I do.
Okay.
I will have her join. Let's see if there's a smaller group. Room 6. Oh, maybe Brian's doing that too.
Okay. Looks like room 1 is a little small.
1 and 6 and 8.
Okay.
1, 6, 8, 9, and oh my gosh. 1, 6, 8, 9. 1, 6, 8, 9. And 12. Are you moving people, Theresa?
I am. Yeah. Sorry, I was just about to say I let a few people in and moved them.
Yeah, we're doing it at the same time.
Yes, which is why I should have mentioned that's what I was doing.
It's okay.
All right, I'm
I
going to
just
want. Go ahead.
I just wanted to keep an eye on where they were going so that they would
Mhm.
we would even them out as best we can.
Yep. I put those 3 into 8, 9, and 12.
Okay,
All right. Well, I'm going to wander into room 1 and kind of see where
Great.
things go from there.
great.
actually be properly diagnosed and then incarcerated when it's possible they're not even ready to be, before being able to address possible trauma and issues and deciding whether or not it's a mental health issue or, a lack of maturity. So there, solutions obviously is we need more resources. We need, the ability to have mental health available 24/7, not a day a week or, a limited amount of time throughout the day, because things happen 24/7. It's just not available. And in the community, if somebody is struggling with mental health, the ability to provide actual help for them, very limited, and it's unfortunate. Or if they're in a local jail, the jail staff is clearly not equipped to deal with folks with the mental health. It's not what they're trained for. It's not what they're supposed to do. So, I mean, unless there is an influx of funding and the people willing to be there to provide those services, the proper medications, the constant ability to provide therapy and to try to reach underneath the surface to try to figure out, where can we be of benefit to you? I couldn't say what a solution would be.
Yeah. But something you said that resonates, right? Like, and how do we start this at a very, very early period in people's lives, right? How do we equip our school systems, right? Otherwise, that cradle to prison pipeline will continue to be a specter hanging over our culture and communities. So appreciate that. Maybe that's where we start, right? That's where we start.
I think so. I think people need to take the actual quality time, even though who has it? Nobody has that time when you're dealing with so many individuals, so many things on your plate. Everybody is overpacked. We all know this, but you have to make the time and take the time to hear them and to see them.
Thank you, Wendy. Everybody, please give it up.
Thank you.
Wendy, appreciate it. So we heard from group 1. What about group 2? Breakout group number 2.
Hello, this is Gail. I was in group 2. What we found is that we each had our own story regarding mental health, institutions, frustrations that we've dealt with. And it was really a passionate discussion of what we've all been through. And the end result of that was that it seems like we're each trying to do something to change things. One person's husband is making changes in his correctional facility due to what he saw his wife go through. And that's just an example. But I really feel even those of us that aren't necessarily in a facility dealt with frustrations, and now they're making changes in their lives that may help them to better deal with what's going on and mental health issues and the situation that we're dealing with.
Yeah, something you said that makes sense, right? I think this is so important for us to figure out how to do this, right? Brian Stevenson often say, unless we close the proximity between us and the problems and issues, it's hard to own that at an emotional level. Intellectually, we all understand, right? Mental health is a problem, it's a constant crisis in our country, right? And so on and so forth. But if it is not personal, it's not emotionally connected, it is hard for people to fight for change, right? So I appreciate that. I'm wondering how do we get our policymakers and police departments, right, to own this, right, at an emotional level, to be tied to this, and not at at an intellectual level. So So it's definitely a call to, right, call for action on our part. And so whatever we do, right, in our respective communities going away from here, right, let us close the proximity between mental health concerns in our community and enforcement and policies, and right, we cannot have this divide, right? The greater the divide, the less focus on that. So appreciate that reminder, Gail. Thank you. Group 3, breakout room 3.
I will go ahead, Raj. I was waiting if any of the other members were going to say something, but if you want to, please jump in. We talked about how, like you said, how it affects us, and we are all affected in our daily life, and how that triggers us to make certain actions. Sometimes react or sometimes act consciously, but also some of the thoughts that the group had was how we need to approach this, not as in a moment of crisis, as a cross section, but as more as holistic level, and maybe perhaps seek out relational connections even with the people who are involved. And some of the members talked about how rural care is challenging because most areas doesn't have some of the access to these resources, and how it is hard to get those services in. But also some of the members talked about how to use the existing system to coordinate care and to build and to provide better services.
Wow. Yeah. Was there something that was said in your group, Doc, that you could share, like a story, a narrative?
There were 2 members, so they talked about how they had family members who needed care, and how that has impacted their view of mental health, mental illness, criminal justice system, and so forth. And I think that often we talked about how that affects the view or the lens that we have.
Yes, appreciate that. Right, again, that it underscores for us to not just understand numbers, right? When our speaker said 80% of the people, and I'm like, wow, that's a lot of numbers, right? Until I know somebody, right? I don't have a face to those numbers, right? So I appreciate that. So that's number 3. Number 4, breakout group number 4, where we are. Who is number 4? Come on, y'all, before I call your names out, because Jody sent me a list.
I don't remember what group I was in.
You might have to call us out.
Huh?
Room 4 included Angie Barnick, Brian Higbee, Dana Burmeister, Lisa Janish, Madeline Schaff, Peter Eichten, Scott Schumann.
Come on, y'all. Okay, we called your name out. Now don't let me shame you. I want to hear you. Oh, man, do we? I think. Okay, so we'll skip that room, right? Room 4, right? We'll go to room 5. Room 5, breakout group number 5. Come on, let me hear this. Kayla is moving in, so Kayla must be number 5. Oh,
there, I'm unmuted.
okay.
Something that I really appreciated that we discussed in group 5 is talking about like preventative measures. As someone who works in the prison, obviously the people I work with have already acted out and have been convicted. But, what do we do before they're at the point of acting out? And we talked about education for children and even just emotions management, problem solving skills, like more of like lifestyle sorts of solutions is something that I've noticed from working in the sex offender treatment program is the lack of sexual education or even acknowledgement of what abuse is, or even that they're witnessing or experiencing, abuse, or, witnessing like domestic abuse within their own home, learning how to report, what resources they have available to them. Something that I also really appreciated referring to that is a role that each person can have that's perhaps not as overwhelming, which is how we interact with the children in our lives, whether we're a parent or not, and what we choose to model to them and how we choose to interact with children and the skills that we can teach the children in our lives on a daily basis.
Wow. Yeah. I love that. Right. I mean, this is some of these solutions are so basic, right? It doesn't really require a lot. And yet we are such a busy life. Everybody here is busy, right? Margaret is so busy, Margaret can't even find the unmute button, right? Sometimes.
Unmute right now. Kayla was actually with our group in group 6, and she spoke very well to what our discussion was.
I thought I was 5.
Really, we talked about the beginning of life and moving forward is so much more important, the preventative and the early stuff versus the trying to remediate it after the fact.
Yeah, right. Yeah. But we are such a reactive culture, right? We've been trained to react versus reflect and respond. So that's why, 911 gets all the calls versus, right, community providers are not getting the kind of calls that are necessary, right? Because our knee-jerk reaction, we are trained to think, right, in that manner. So appreciate that. Group 6. Where's breakout group number 5?
And let me just, as we're waiting
That
for
was
someone
group
from.
Sorry, that was group 5. So we're on to group 6 now.
Okay. Group
And
6.
let me also mention that I want to be sure to respect people's time. We said we're going to end at 11:45. So maybe there are some groups who would like to put their thoughts in the chat, or certainly people can stay around a few extra minutes, but just want to be sure we're,
Time discussing ways. So we are not hearing from group 6, you said, right? Okay. I want to just invite group 7 because,
I can talk from group 6. Sorry if no one else wants to.
Go ahead, Becky.
We covered a lot of stuff. One thing that really resonated with me was talking about youth and what they're doing and how we can learn from them in the future, to as their elders speak out and be more vulnerable and put ourselves out there. Like we were talking about, I talked about every protest I've been to has been all people that are younger than me that are there and willing to put themselves out there for the community and fight injustices. And it's been really refreshing to see these young people do that. And we also talked about, the school to prison system and how that really affects young people. And as a mental health case manager, how I see like the kids that I work with and how they have these barriers that start them on the pipeline. Like for instance, in COVID, a lot of the kids got charged with truancy because they didn't have access to what they needed to get to school, distance learning, and be successful. And that's not their fault. And we need to do better by them to make sure that they thrive in the community. We talked about a bunch of other stuff. If anyone wants to jump in, we really kind of jumped around.
Good. Thank you, Becky.
Right about that. We talked again like the other where money. We need to get that money out there so we can create these care teams and everything, so that if the training is there and the student, that the young population and even the older that have these mental health issues can be taken care of, and so that they are not incarcerated because somebody is uncomfortable and calls law enforcement to come talk to them. So we talked about money as well, and Becky was wonderful, and everybody talking about the experiences and what they're saying, because yes, our generation, my generation, being a teenager in the early 80s, is completely different from what our world point was dealing with at that time versus what they're dealing with now. And they're very vocal, they're out there, they're fighting for justice. And I think it's very amazing how these young people are standing up, like Becky said, how she's seeing the 20-year-olds going out there and fighting for justice, social justice. And now we as elders need to try to find a way to help get procedures and money out there, either federal, state, city, whatever, to put these things in place for them. So I think our team, our little breakout team was wonderful in discussing that, because I think we all are a little heartbroken about what has been happening with everything with the deaths and the targeting. And we just want to try to see this world become better.
Oh, wow. I see that we're past the minute, so I want to respect the time and give yourself a big applaud and give yourself a big hug, y'all. Just hug yourself, right? Come on, hug yourself. It is so important that we know that this all matters, right? As we move forward, right? As Michelle Umster said, right, in that poem, A Vision for Justice, she says that it is all about the babies, taking care of our babies, the babies until 7 generations, right? The babies we must love in ourselves, in our homes, in our communities, and in our streets, right? We have to bear witness. We have to create the safe and brave space. We have to learn from the past to see the future, right? And so let us make this moment that we have been together a movement in our respective communities. Right? Let's do that. Everybody, appreciate you, love you. Thank you to the team. This is amazing. Teresa, Jody, whoever.
I just also want to thank the team, Jody and Brian, doing so much work behind the scenes. Dr. Darshini, Dr. Raj, grateful to be part of this. And I want to acknowledge, again, the offices of the Dean of Students, Provost, and President for their support. And we will, everyone who is at today's, or everyone who's registered for today's event, will get an email soon about our June event, which will feature Naomi Gaines Young and her powerful, powerful experience. So thank you, everyone. Thank you so much.
Thank you, Theresa.
Thank you. Thank you all for including me in this important topic. I hope that moving forward, things start to change and get better. Look forward to it. And thanks again. Very important.
Thank you, Holly.
Thank you, Holly.
Larissa,
The
do you
birthday
need
girl,
students to
enjoy.
stay?
Love all your hats that you're wearing.
No, whichever of my students asked you need me to stay. Was that you, Becky? No, not at all. I gotcha.
Okay, thank you.
But
thank you for the recommendation. This was wonderful.
Yes, thank you.
Thanks, everyone.
Yeah, thanks a lot. Wonderful discussion.